What's the hardest thing for new MBA students to wrap their head around about clinical leadership? Neel Pathak is the program director of Creighton's Executive Healthcare MBA, a national Baldrige examiner, and a systems strategist at Johns Hopkins. He's been shaping the future of healthcare leadership from the classroom to the boardroom to the front lines. In this conversation, we talk about why evidence-based decision-making is more than just collecting data, what real leadership looks like when systems get messy, how care coordination actually gets built beyond theory, and why AI isn't the answer, but alignment is. Neel brings a rare combination of clinical roots, operational savvy, and national perspective. He's trained leaders, fixed systems, and challenged the way that we think about strategy, quality, and ROI. If you care about building models that last, this one is not optional. What's the hardest thing for new MBA students to wrap their head around about clinical leadership?
If they don't have a clinical background, then fully understanding how clinical leaders operate and what space that they're going to be in and how can they use their managerial skills in the clinical setting is something that they need to wrap their head around. Now, if they do have the clinical skill and they're jumping into a leadership position, a lot of time what happens is just because you're a clinician, you're given a leadership position because of mission that you're managing a department, you're vice chairing a quality committee, but you don't have the management skills or the tools to run those committees or to run those departments. So there are two aspects to this. If you're a clinical person who's put into the leadership position, but you don't have the management tools, that's your perspective of gaining some of those tools and resources in the MBA program.
And what do you say to people who say that why even bother having an MBA program? Why come from an academic perspective? Doesn't that kind of not prepare people for the real world settings?
So I think the reason you would want an MBA, especially when you're thinking about a healthcare MBA, is you need to understand how all parts of the system are connected. If you're great at being a clinician, but you don't understand the nuts and bolts of the overall system or the administration side of it, maybe you're lacking one perspective there. So an MBA will help you to see the full picture, if you will, in terms of, yes, you not only get the clinical side, but you also get the administration side. And that's where the clinical leadership really excels, where you get that full picture of not only understanding strategy and leadership, but also understanding the nuts and bolts of finance, of operations, of revenue cycle management, of population health, a lot of other things that go along in running a health system.
Do you feel like having that high level perspective and kind of looking like from the top down at some of these things, you think it helps people kind of like depersonalize and maybe like take some of the emotion out of their own like negative experiences about like what healthcare leadership is and that kind of thing?
Yeah, I mean, any healthcare leader, I think, makes decisions. When they make decisions, those decisions affect a lot of people. So when a healthcare leader is making decisions, it's important for the leader to understand that they check their own biases and lend themselves into some sort of an evidence-based decision-making framework. It could be anything. It could be a SWOT analysis. It could be a shared decision-making model. It could be an evidence-based decision-making model. But it's important for leaders to have that understanding that their one decision can impact hundreds and thousands of people within their system. So how can this decision be not only because, I think this is the best way to do so, but no, this is really based on evidence, based on stakeholder data, based on clinical data, based on experiential data. It looks like this is the best path forward. And let's take that path forward. So from an administrator's perspective, from a leader's perspective, considering all the different elements and triangulating that evidence into decision making is a key skill.
Well, one thing that I've noticed about these frameworks is that it's almost like the logic doesn't guide the decision. The logic helps you explain and justify the decision.
Yeah, so that's a great way to segue into a topic of, people usually ask, I just need more data to make decisions. Yeah, even if you get a lot of data points just to make decisions, data itself does not lend into decision making. Data is a part of decision making. You need quantitative data, but you also need to understand and use your critical thinking judgment, your skills, and understand the overall issue from a stakeholder perspective. Who is this affecting? Are we listening to our stakeholder needs? And then triangulating those three sources of data points to make that decision. That's where the real test of leadership comes.
Can you give me an example of a success story you've seen when they move into that kind of thinking and when someone has kind of mastered that art, at least, of...
Well, lots of our healthcare MBA graduates, when they get into their capstone projects, that's the culmination point of their MBA, where they're using a lot of their skills that they've learned from the MBA program, and then they're applying those skills and tools in a real world project. And this is where they're using their critical thinking, their decision-making skills, the tools that they've picked up from the program, the tools that they've picked up from many courses, like the SWOT analysis, like the financial modeling, like the PDSAs. And then they're using that in a real-world project. So, of course, the healthcare MBA helps them, equip them with those tools and resources in challenging decisions like that. And then those students go out in the real world and apply those same sets of tools and resources in some of the settings that they are in. And we've had students from a lot of settings, including academic medical centers, including critical access hospitals, community hospitals. And some of the projects that they worked on are building a whole new neuroscience center, to improving transfer care operations, to improving operational efficiency in surgical settings. So there's so many examples that our students have led some of these projects in.
For people who are just starting to think about expanding their careers or expanding into leadership in a more kind of impactful way, what are 3 immediate kind of actionable takeaways that you would have for them?
Great question. Those who are starting in this healthcare leadership space, I think be constantly curious, because there's a lot to learn in the healthcare industry. There's lots of moving parts. Even if you understand the acute care space, and there's this long-term care space, there's this population health space, there's retail health space. Yes, healthcare is broad, and being continuously curious about how those different sections intersect and how does it really help inpatient care is important. I think the second thing is always have your North Star ready in terms of why are you in healthcare in the first place? Are you here to make patients' lives better? Making sure that you are in it for the right reasons. Continuously have that mindful thinking and reflection as you advance in your healthcare leadership journey is also important. And third thing is be on the forefront of learning. Be a lifelong learner, because things change. Healthcare changes rapidly. Just in the last 4 months, there's been many bills that have passed, and hospitals and health systems are trying to keep up with so many things. So be on the lookout for new things in terms of what's coming down the pike. How can you improve your skills as a leader with the things like AI, population health, informatics that are gaining attention? How can you as a leader be aware of those things in the first place? And then second, utilizing them in your data is important. So those are the 3 things I think any leader coming up in this space should be aware of.
How long have you been working in this space?
So I've been in this space for over 15 years now. I'm a clinician by training. I'm a physical therapist. So I practiced as a clinician for a couple of years. Born and raised in India, practiced there for a bit. I moved to the US about 15 years ago now, and decided that I wanted to learn more about the business of healthcare. So that's how I went into the Masters of Health Administration program through University of Creighton in Pennsylvania. And after that, I stopped practicing as a clinician, but not because I didn't like being a clinician, but because I was more interested in the business of healthcare and understanding that bigger picture, understanding that systems thinking. And because of that reason, I just stayed into healthcare administration, practiced as an administrator for a couple of years. And then academia came knocking, and continuing my 2 roles, still staying relevant and current in the industry, working at Johns Hopkins as a project administrator, and leading a full-time healthcare MBA program at Creighton University. And I also teach at a national level with the American College of Healthcare Executives for their virtual and in-person sessions. So that's how my career journey.
I really relate to you coming from the perspective of a physical therapist, because I think that when you have that perspective and you understand sort of the wear and tear, you understand what the healing trajectory or the disease trajectory looks like over time outside of the four walls of the hospital. You get to kind of understand health outcomes in a different way. At least that's been my experience working like closely with PT, OT, working in SNFs and home health and hospice and that kind of thing. And that's certainly shaped my perspective. And I've taken that, I think, into every single aspect of this program. Do you feel like that background has shaped your perspective and your trajectory and what you bring in, to quality improvement, education, and everything else?
Certainly, yeah. I mean, like I said, it's not because I didn't like being a clinician. I left being a clinician. I still love being a clinician. Actually, neuro patients were something that I really enjoyed treating. So patients with a traumatic brain injury, stroke, Parkinson's, I was fascinated by that because I could see what the impact of therapy on their outcomes, right? But then once I was exposed to the business of healthcare, it's like, oh, I would love to learn more about it and maybe I can have an impact on maybe more than one patient at a time. And that's how I really got involved into the business of healthcare, if you will. So, did I miss being a clinician for the first couple of years? Yes. But at the same time, I still use, even today, in all of my QI projects in teaching and academia and healthcare management, I still use my base and learnings from being a clinician because I can understand, one, from a clinical perspective, what the patient might be going through. Second, from a clinical perspective, also that what needs to be done from a clinical care perspective, and then how can we stitch the administration perspective to it, joining the clinical part and the administrative part for the patient is the lens that I bring in with my clinical experience and the administrative experience.
It definitely shows. Can you walk me through? I mean, you happen to have like at the top of mind any example or an experience where you saw, because of that like perspective, you saw something differently in, a program or a project management setting?
I mean, one of the things, so I'll give you a story on that. But when I was an administrative fellow at Aramark Healthcare, I was asked a question, why did you move into administration and what would you like to do? And my response to them was, I moved into administration because I learned the US healthcare system and I do know that the US healthcare system is fragmented and patients often get confused even accessing the system, even if they are having the best of knowledge and intentions. So my one-liner to them was, I really want to make healthcare simple for our patients. And that's really my North Star, why I'm here. And because of that, one of the examples, like you asked, at Hopkins, I'm involved with the patient experience team. I lead a patient experience team, a committee at Johns Hopkins. We call it the Ambulatory Patient Experience Council. And through that, we've led many patient improvement activities and projects, if you will, working with our practice sites, working with the leaders of the practice sites, the physicians, administrators, clinic managers, nurse managers, frontline staff, all working together to improve patient flow, to improve wayfinding for our patients, to improve the overall care experience that they get at the front desk, to improve how providers communicate with the patients, to improve the care coordination services for the patient. To that end, after having a lot of these discussions, we realized that we needed a care coordination center that was centrally managed for our patients. So because care coordination services were kind of scattered across our different clinics. So we still offered those, but either the patients were not aware of some of those services or they were just fragmented in different settings. So we realized that there's a need for creating a care coordination center for our outpatient center. And I was a part of that project as well. And happy to report that project is now live and we have a care coordination center that's centrally managed. Of course, it just went through its pilot stages and we're hoping to grow that center. But really at the heart, the mission of that was to how can we provide wraparound services for our patients in an easier way, rather than them going through 10 different people or calling 20 different folks to understand some of their next steps. So that's how we created this care coordination center, if you will, at our outpatient center to make our patients' lives a little bit easier.
Well, you finished your PhD pretty recently, if I remember, and it was on the No Surprise.
So partly. So yeah. So my doctorate in healthcare leadership was with the University of Alabama in Birmingham. And like I said, patient experience is at the forefront of some of the things that I want to do.
That's just what I was going to say.
In that line, so I chose my dissertation topic on price.
I just wanted to ask if you found this video insightful, and if you did, please click on subscribe so that we can continue to ensure no one gets left behind in the value-based future of healthcare.
Transparency. So back in 2021, there was a law that came down that required hospitals to post list prices on their websites. And the intent of the law was, well, first, there's just not enough transparency about pricing in healthcare. And we all understand that. So the intent of the law was to take one step forward from there and at least have the list prices of all of the services that the hospitals could offer available in an easy to understand manner for the patient. So, okay, well, that was a good intent. However, at the end of the day, the list price is not what the patient ends up paying. It's what the contracted price that they have with the insurance company, what their deductible might look like, and ultimately what their out-of-pocket payment might look like is what is most important for the patient. So while price transparency was a step in the right direction, there was still a lot of things that needed to be done to fully understand the total cost of care and what that patient's perspective from that cost of care might be. So my research really asked a question, and it was original research where we asked about 600 participants. So we surveyed about 600 participants about, one, have you heard of the new price transparency law? And second, if you have, did you go to a hospital website? So did you utilize the pricing information that was available on the hospital website to make a decision for choosing a provider? So we learned that about 20 to 30% of the patients actually used that service. About 40 to 50% of patients had heard of this new law. So, of course, back in 2021, that was a newer law, but now it's becoming a standard practice. Most of the hospitals are now complying with it, and there are additional measures for that law. But that was one part of the survey. The second part of the survey was, well, now that you have given us that whether you've used the pricing information or not, how important is the list price information for you as a consumer in making a decision about choosing a provider? Do you really choose a provider only solely based on list price, or are there other factors? So we asked a question that included multiple options, which were the quality of the provider, the social media rating of the provider, the reputation of the hospital, the list price, and ultimately, what's the out-of-pocket payment that I would pay for seeing a provider, for choosing a service. And the surveyors, the participants responded that the list price was number 4 out of the 5 options that they would consider. So it was really not at the top of their decision-making criteria. The top was quality of the provider and the out-of-pocket payment. So really that's what's important for our consumers. So at some point, especially with the new laws that are coming in, focusing on the payer side, where now the payers are required to disclose some of the prices, what you would end up paying, assuming that you would take a particular service. So giving out those cost estimates before you buy into or opt into a service is something that's coming down the pike as well. So we'll see how that happens. But ultimately, I do think that having those transparency rules around pricing and what your cost might look like as a patient is the bare minimum that we could be doing as a healthcare industry.
I see. Okay. Did you ever find that it was like a deterrent in general? Like, did people just like kind of forego care when they realized how much it was? Or was it just like if they didn't have insurance?
Yeah, I mean, we know that there's a huge amount of population that just doesn't go for their needed care because of cost issues and just because they cannot afford it, or it's just their insurance does not cover it. So we understand that, but that was really not specifically looked at for the research that I did.
Okay, these were people that had already agreed to go.
Yeah. So assuming you had insurance and assuming you were looking for a provider, here are some of the questions that were.
I see. Yeah. So with what kind of recommendations would you make for healthcare systems that are looking at incorporating pricing into their marketing?
Yeah. I mean, look, it is the right thing to do, but it's also a cost for the health systems at the end of the day. I mean, complying with these laws is costly. So we understand the push and pull of this. But at the end of the day, I mean, if price transparency is the law of the land right now. So I would recommend that most hospitals comply with those price transparency requirements. But it's not just the hospitals. It's also the insurance companies, the payers are subjected to some of the laws that affect them in terms of how they make some of the information available to their patients before they receive the service. Overall, I think consumers are looking for this information. I think that we owe it to them as an industry. Why should healthcare be any different than other industries? I mean, you don't go shop and then just pick a product without knowing its price. So I understand the nuances and the complexities that occur in providing specific pricing that may, because complexities of a patient might change and that may impact the overall total, the overall cost of care. With that understanding, for those things that we can provide, we should provide. And where we don't have clear data, we should be upfront that, hey, because of the complexities given in a particular type of care, we may not have the most accurate estimate right now, but here's the general trends and here's what we could be expecting, and keep the patients apprised, if you will, throughout their process. We owe it to them.
In the last 15 years, what's changed the most about healthcare, just in general?
Well, I'll give you this. When I was in grad school 15 years ago, we were talking a lot about movement from fee-for-service to value-based care. And 15 years from then, we're still talking about it. So the point I'm trying to make is healthcare moves at a slow pace than other industries. Have we made progress? Yes, I think we have. With the focus on value-based care, with the focus on bundled care payments, I think overall, if I have to put some points on what are some of the major shifts, I think consumers are becoming more and more aware of their care needs. Consumers want to participate in their care needs. Yes, I think patients and family members want to be aware of some of the care needs that their loved ones are having. You can see, 15 years ago, we didn't have these MyChart portals, patient portals everywhere like we have now. A lot of movement is occurring in terms of how can care be made simpler? How can care be accessed faster? So I need the appointment now. 15 years ago, hey, my doctor's not available. I'll wait it out a couple of days. But there's data that's out there that suggests, especially with the millennials and the younger generation, that if they don't get the appointment, say in the next day or so, they might be willing to switch providers. For them, it's the episodic nature of the care that's more important versus building the relationship with a primary care provider. So there's lots of shifts that are occurring, if you will, in terms of how patients are consuming care and how they're accessing care.
I think you're one of the first persons to not just immediately go to tech and AI.
Yeah. Yes, AI is the buzzword today. And yes, it's being used in many of healthcare facilities. But look, let's just be real. We don't know what we don't know. And it's okay to say that. We're learning in terms of how the adoption of AI is going to be, where AI is going to be used in what kind of setting, in what kind of services. We know it's being used in revenue cycle space right now. We know it's being used in the clinical space in terms of scribes and other stuff. And I think the use of AI is continuously going to increase, but we also have to be mindful and cognizant about the fact that just because there's a new technology doesn't mean it's going to change everything. We're still going to need humans. We're still going to need clinicians. We're still going to need administrators. I always say this to my audiences, that think of AI as a strategy enabler and not the strategy itself.
Yeah.
AI is there to augment stuff, to enable strategy that you've already decided or thought through. AI itself, just because AI is available, it's not going to solve world problems for you. You have to think through how can you use the technology in a meaningful way to make life better for your clinicians, for your administrators, for your patients.
This episode was brought to you by the Farnham Hotel in downtown Omaha. I've actually been traveling here a lot for the past year and a half for my MBA degree at Creighton University. And I get asked a lot for my travel recommendations. And every time I come here, I only stay at the Farnham. I don't even have to leave the hotel because there's so many spaces for meetings, working solo, collaborative spaces. There's great dining downstairs. I could not recommend it more if you're traveling here for business.
In, I guess, riffing off of that, in now this data overload kind of situation, that environment that we're all working through. What performance metrics should care teams be using today if they're implementing strategy around social determinants of health?
Yeah. So there's a lot of data available out there, like you rightly said. A lot of care teams and administrative teams kind of suffer what I call paralysis by analysis, meaning they have so much data at their fingertips that they're tracking hundreds of metrics at any given time. And then what happens when you do that? It's a good thing. But it's also a good thing to step back and figure out of the 100 metrics, what are some of the 3 or 5 or 7 metrics that I really need for the betterment of our patients, for the betterment of our experiences, for our clinical members, for our administrative team members, for the overall care processes that we deliver. And that becomes the key challenge of leadership, to figure out, as Kevin O'Leary puts it, how do you find the signal from the noise? There's a lot of noise with all of the data points that are available right now. How do you find the signal from that noise? How do you make the right data actionable is the key, right? So, and what are some of those key points may differ from the setting that you're in. I mean, at the end of the day, it's the patient outcomes that matter. Are you being safe? Are you preventing harm? Are you preventing infection? Are you providing the best possible experience? I mean, those are the key metrics that any health system leader would be looking for, right? So yes, focus on some of the key things that are constantly true, that are constantly reliable, and we'll need them for care delivery for our patients. So that's my take on it.
So if you were looking at these non-traditional kind of clinical models, I'm just asking for anybody that's in that space where they're kind of looking at building a business case for things like transportation, food, housing, that kind of thing, and partnering with health systems, large and small. What are some key metrics that you would look at there?
So I think that's a much broader question, one. So first, we know that there's data out there that suggests social determinants of health play an important role in the health outcomes of a person. So it's not just what care they deliver. It's a lot of those wraparound services like we talked about, where they live, how they live, access to transportation, access to different services. A lot of those things matter because you're caring for an individual. You're not caring for just one thing that they're suffering from. So lately the conversation has been shifted, and rightfully so, I think, from that episodic care of, why are you here? We'll treat you for this, but we don't really care about other things that are affecting your lifestyle. And people are rightfully asking the question, well, if the patient goes back to that same environment which caused the harm in the first place, and we're not going to fix the problem, and we're just putting a Band-Aid on that, we're going to see that patient come back twice, thrice, 4 times, possibly back in our ED, and raising the total cost of care. And that just strains the system. So rightfully, I think as an industry, we're asking the right question. How can we care for the population? And if you do ask that question, then it becomes, well, how do you do that? What are the metrics behind it? And what does that even mean, caring for a population? So is it really focusing on preventive stuff? So one of the key metrics, like you asked, could be, how can we prevent? How can we allow for more funding to go to preventive services? Why should we wait till we are worse in our health and then go to a provider? Why can't we invest our dollars in making folks healthy in the first place? And there's lots of case studies out there. Geisinger Health System in rural Pennsylvania is one of the key leaders that took on this project of population health. And they started sending out colorectal cancer kits to their patients. And this was their one way of screening their patients for colorectal cancer. And there's many other examples out there. Health systems have decreased ED utilization because they're stepping up and amping up efforts on preventive care. So that is one key metric that you can think of when you're thinking about population health, is how can you actually improve the health of the population first, and then meet where they are in terms of taking care of some of the needs that they might have. Transportation, housing, food. There's so many things that affect the health of an individual. And then focus on programs that could help in some of those areas.
Could you apply the Baldrige?
It really depends. So you really have to understand. So the Baldrige framework, at the end of the day, is a framework that was created for U.S. businesses. And the reason it was created is that we can sustain ourselves to be leaders in business by operating our businesses more efficiently and by using proven, credible frameworks that are out there. So Baldrige was an attempt to create a framework that could help U.S. businesses. And then it proliferated into healthcare, into nonprofit, into academia. So there are different frameworks for those different settings. Now, healthcare, of course, has a framework, and it really is meant for organizations to look at stuff from a holistic perspective. What I mean by that is you really have to take stock at what is your organization's profile, meaning why do you exist? Who are you caring for? And these are questions that seem simple, but if you put 5 executives in the room and ask those questions, you might get some different answers in terms of who your customers are, right? So really taking a deeper look into why do you exist as an organization first. And then really Baldrige has this approach of Adley and Let's See, and I'll tell you what that is in just a bit. So when you think about processes, when you think about, well, how do you do leadership development, or how do you hire leaders, or how do you create strategy plans? So Baldrige asks some of those questions in their framework. What it's looking for is how well aligned and mature are your processes. So when you think about processes, you're thinking about approach, deployment, learning, and integration. Meaning, how is your approach to leadership development? How is leadership development training deployed across the organization? What are you learning from those training opportunities? And how well is it integrated across the organization? So that's thinking about it from a process perspective. And then when you start thinking about it from an outcomes perspective, you're also looking at multiple things. One, you're looking at the level. When I talk about the level, meaning here's where you are at in 2025, in the month of May. That's the level. Here's the data point in May of 2025. But you also have to look at trends. Where were you last year? Where are you going to be in the next couple of years? You should look at some of the trending data, right, from the past years. Then you need to compare yourself with other like-minded organizations. So an academic medical center is going to compare their benchmarks to another academic medical center, and we got to make sure that where do you stand in terms of comparison with those other similar organizations, and then again integrating it across the organization. So when you're thinking about results, you're thinking about levels, trends, comparison, and integration. So the Baldrige framework is unique, is really comprehensive, and it can be applied across the wide variety of settings. But you have to be very careful and mindful that you need to have organizational leadership buy-in for that. And it's not like a flavor of the month. It's a journey that the organization typically embarks on. For folks and organizations who wish to apply for the award, now you don't have to apply for the award, you can just use the Baldrige framework. But typically those organizations who win the Baldrige at the national level, they've been on the journey for anywhere from 6 to 8 to 10 years. Wow. So it's really not that flavor of the month that, hey, I'm going to pick this project and work on it. You really got to be mindful. One of the things that I talk about a lot with my healthcare MBA students at Creighton is, when do you use the right tool for the right setting? Yes, you're aware of a lot of the tools, you're aware of a lot of the frameworks, but it's also important, when do you use what tool and why are you doing that? So making sure that you use the right tool for the right problem is also a key skill to have.
How do you know when you should start looking at process or looking at outcomes when it comes to evaluating social care?
I think both are important. You have to have the right process. You have to have the right players involved in the right process. And then your outcomes will tell you the story, whether it's working or not. So you have to look at it from both angles. If you're not meeting your outcomes, well, is it the process that's the issue? Are we tracking something's wrong? Are we looking at the right outcome measures? So it's really a mix of both. And you got to have an understanding of the process metrics and outcome metrics, regardless of the setting. It's not just social care, but any setting that you're in. You want to be mindful of both.
Makes sense. I think there's sort of like people want to look at the outcome when it comes to social care right away,
right? But
it can take so long to get the full picture. So some default on process too, but then you kind of get into that danger zone of like mission. What is it called? Mission creep.
Yes, and there's something called scope creep as well.
Oh, right, yeah.
So it's a good question. So here, I think it's really the organization's purview in terms of how much importance or weightage are they giving to social care services. Because the real question is, of course, organizations have to make money, and of course, leaders will be asking the question, well, what's my ROI? And in healthcare, there's also this thing called, it's just the right thing to do. We got to do this because it helps the patient. So we have to combine those perspectives when you're wearing the hat of the leader and figure out, well, is this the right thing to do? Social care services, care coordination services, thinking about population health, thinking about social determinants of health, I think provides a very good ROI for our leaders. And for that, we have to look at it not just from a myopic lens of why am I funding this initiative, but if you're funding this initiative, if you're really caring for the health of a population, maybe that person improves and does not show up in your ED month after month. And if you just calculate those costs about ED visit a month over month, versus providing some wraparound services, you're not only improving the actual health of the patient or the population, but you're reducing your costs, overall costs of care. And that's also important in the larger scheme of things. So there's multiple ways to measure ROI. It's really what the organization is thinking about in terms of where to allocate those resources and what are they really looking out from that investment.
Yeah, I think coming from large safety net hospital system, one of the number one things I would always hear new residents say is that this isn't medical, this is all just social. And I can definitely see why it feels that way. But you also think of like kind of almost the cost of opportunity, all the things that, we could be working on or you could be innovating on if you weren't kind of constantly solving the same over and over again for the same kind of population and, do some of that upstream work. So more of a philosophical question, I guess.
No, I mean, because it's not mainstream today, does not mean it cannot be mainstream tomorrow. We've been trained to look at things in a way that just existed for 30, 40 years. And now we're learning things that, you know what? Yeah, it makes sense to take care of an individual as a whole. Maybe 15 years from now, we'll see a different story. So it's just, we just have to be positive. Keep doing the work that we know is going to help patients. And I think we'll catch up to it in a way that this becomes a standard of care. Because when you look at it, I think now it's a requirement to capture social determinants of health within the medical record, which was not, or it's getting there.
There was a threat about it to pull back on it,
Okay.
But then you have the introduction of new Z code, so it's very mixed messaging that we're getting.
Okay.
Yeah,
But
we'll see in August.
We'll see how it goes. Yeah, exactly.
Yeah, but I think in the broader scope of things, there are sort of like the expansions and contractions that need to happen, for these larger wave things. And that's such a positive note to end our discussion on. But I wanted to throw last thing at you. You could redesign the executive MBA program from scratch to address 2030 challenges. What would you add?
I think when we designed the executive MBA program, we're very mindful in terms of making sure that, one, we stay current with the trends that are happening. So that's when we designed the program 7-8 years ago, keeping that thing in mind and making sure that we adhere to the most important metrics that are out there from a program perspective. So that's why the healthcare MBA program is accredited dually by AACSB and by CAMI, which makes us we're in a very small company of maybe less than 10 programs that are dually accredited by CAMI and AACSB. So we want to maintain the highest level of education and make sure that our academic standards are high for our students. Having said that, from a program redesign perspective, we actually did that just last year. We introduced a course on population health. So the cohort after you is going to get a course on population health. They're going to get a course on health informatics. They're going to get a course specifically dedicated to current trends. So we've created a placeholder in the program itself where year over year, we're going to invite new faculty members about what's happening in the industry today. So this year it might be AI. Next year it might be value-based care. The year after, it might be social determinants of health. It could be anything. But we have a placeholder for that now. So we are strategic about making sure that their program stays relevant and current for next steps. And when we learn new things, we will make sure that we continue to redesign the program to make sure that our students are getting that best experience that they deserve.
So not a thing. It's already perfect.
We'll see. Like I said, I'm into process improvement. So when I get the data, when I understand the need, it's because we just made the change last year. Maybe in the next couple of years, maybe AI, the advent of AI, we may have to introduce a smaller course on applications of AI in healthcare. But again, we don't typically take knee-jerk reactions. So we look out and see what is happening at a global scale and what might really be needed for our audiences, especially in the healthcare MBA section. And if and when we realize that need, we fill that with additional courses, guest faculty members. There's a lot of change in terms of how content is consumed as well. We'll constantly think of delivery modes, online, in person. What makes the most sense? How can we use simulation-based learning, like the Friday night at the ER that we use, or the cybersecurity simulation training? So adding more of those experiences that bring home some of the content that we're teaching, it will be something that will be constantly looked at. So it's not like, oh, let's change the program this year. We're continuously listening. We're continuously looking for new things. As we realize that this is something that's a good fit for our students, we make it happen for our EMBA folks.
That sounds like a really exciting future for the EMBA program. And thank you so much for our talk today. Thank you for your leadership. Thank you for an amazing EMBA experience. Yeah. And I think we're good. I'm going to leave it at that.
Thank you. I appreciate the